So the STICH program has been a labor of love. We initially were funded and continue to be funded by the NHLBI since 2001. We're finishing our last year of funding in that program. As you know, we showed a 10-year difference in mortality rates in favor of surgical revascularization versus medical therapy in patients with chronic heart failure and reduced ejection fraction. When we've looked at evaluating, which is what we're doing now, any important subgroups, be it women, be it patients who are at high risk due to lower ejection fractions and larger volumes, whether it relates to some work that's going to be coming out shortly on patients with high or low levels of comorbidity. Regardless of the groups that we look at, the benefits of surgical revascularization are very clear and consistent. In fact, actually, one of the messages that has come out of our continuing probing of this important data set is that the higher the risk the patient, the more likely they're going to have a gain in favor of surgical revascularization early. In other words, the higher the risk, the more to gain. The only addition to that is the issue of age, which we published on last year in a paper in Circulation that showed that the benefits in favor of surgical revascularization were similar across the age span, but since as we age, the likelihood of having a non-cardiovascular related cause of mortality increases, as is obvious to the audience. The relative improvement is substantially markedly greater in the younger population. So it's not appropriate to wait in a young person because the benefit was much much greater to get revascularized early, and you carried that benefit out for 10 years in our study. And so I think what we've shown is, regardless of age, we should be looking for these patients. If patients present with heart failure, what we have learned from other data sets is that we don't consistently look for coronary disease, and we need to, because this is something we need to treat not only with our guideline-directed medical therapy for heart failure, but for coronary disease, and that we have shown that an approach that includes bypass surgery leads to long-term benefits. Now, what's the future for the STICH program? Well, like I said, we are very proud of what we've accomplished over these last 17 years. There's a group now multinational organized now to start looking at where we go from here. As you know, there's been a lot of interest in whether other approaches to revascularization, for example, percutaneous approaches, might provide the same benefit as the surgical approach we studied in STICH. In STICH, we did not include PCI as a method of revascularization. There's many reasons to think that there may be an advantage to PCI over surgery. There's also a lot of reasons to think that there might be some risk to PCI over surgery. And so the evidence is quite quite out there for really the need for a comparison, as PCI approaches have really technologically improved, as surgery has improved, and now that with this evidence from STICH, I think the time is now for a trial to evaluate whether there's a benefit of one strategy of revascularization, meaning surgery, versus a percutaneous approach. And there's a group of countries and investigators around the world now speaking to this, and we're very excited and hope to see this move forward.